All right. Well, I think we will get started in the interest of time. Thank you so much, everyone, for joining us for this session this afternoon. My name is Geraldine Hoover. I work for USAID based in Washington. I'm a registered nurse by training, and I've worked in HIV care myself. So this is something I care a lot about, the work environments that we create for the healthcare workers that are employed through our programs. So I'm really, really excited to facilitate this conversation today. I work as a healthcare workforce advisor for USAID based in Washington. And we have a really excellent panel joining us today. We have Rahel Sheza from the Benjamin Mkapa Foundation from Tanzania. We have Sam Phiri presenting on behalf of colleagues from Partners in Hope in Malawi. We have Herbert Kisamba from JCRC in Uganda. And we have Chantal Smith from Match here in South Africa. Health workers form the center of our systems, which deliver essential HIV and other health services for communities. They also adapt and respond during emergencies, as we've seen very recently during the COVID pandemic. It's really important to ensure that health workers are equipped and protected, and that the work environments within which they're doing their jobs are supportive. Meeting those conditions is both an ethical issue to ensure the wellness and engagement of the staff that are in our programs and ensure that we're supporting them. And it's also a long-term issue for the health workforce. If we're losing people because people are getting so burnt out that they are not continuing in their jobs, or that the environments are too difficult and too stressful, that's also a sustainability consideration, because then we're losing institutional memory by losing staff and having staff turnover all the time. So I think these are really important things to discuss, these different aspects of how we create supportive and sustainable work environments, and how programs can build local systems to help support these areas. So today our conversation is going to talk about the impact of sufficient staffing and how changes in workload practice can impact staff workload, the importance of promoting open communication among staff, the role of strong leadership that supports two-way engagement with staff, and support for health worker wellness and mental health. So we will have we'll hear from each of the panelists, and then we'll have time at the end for question and answer and for broader discussion. So I'd like to hand it over to Rahel first. You can come up here to the podium. And if the others want to come, you can either sit here in front, or you can just come up to the podium, whichever you prefer.
Okay. Hi, good afternoon. As I was introduced, I'm Rahel Sheza. I worked with Benjamin Mkapa Foundation, implementing a USAID Afya Endelevu activity. And the activity is focusing on using of data and service delivery data to continuously allocate and relocate human resources, as well as creating productivity environments so as to accelerate service delivery. And I'll be presenting a case of a health facility, which is a district hospital in Zanzibar, that we supported through this activity and the changes it made over a one-year period of time. So between January and September 2021, many health facilities in Tanzania have been overburdened with the provision of essential health services, as well as COVID-19 related services. And Makunduchi District Hospital, located in Zanzibar Island in Tanzania, is one of these health facilities with only 19% of the required human resources. The facility experienced a significant increase of clients from the 92 from the previous period to over 151 clients in a day. And this I've attributed to increase of working hours from 10 hours to 16 hours a day, a lack of shifts, day offs, extended waiting time, client waiting time up to 3 hours, and sometimes inability of the healthcare providers within the facilities to attend all the clients that attended, in their day. And as well, this attributed to low vaccination uptake because this is one of the designated vaccination sites in Zanzibar. So USAID Afya Endelevu activity supported this facility to allocate additional human resources for health, as well as work with the local structures to create a more productive working environment. So how was the HRH needs were identified? The HRH needs were identified by using the workloads and the service delivery indicators. For this case, the antenatal care tendency, the client flow, facility deliveries, as well as the human resources were used as indicators. And workload indicator for staffing needs tool, which is a adopted WHO tool, was used. And out of this assessment, priority were identified, needs were identified, but because the resources were not minimal to meet all the optimal requirement, so prioritization was done, and by using just administrative reviews. And concurrent to this, because placement of HRH alone will not be addressing the critical issue of services. So what the activity did was also to run a productivity assessment, and the productivity assessment aimed at identify the productivity-related barriers. And after identification of the productivity-related barrier, which was done through a consultative process, engaging the local authorities, so the gaps were identified and remedial plan was developed. And the development of the remedial plan was done through a co-creation process. And after the setting of the remedial plan, we worked with the local structures within the facility to integrate or mainstream the remedial plan within the routine healthcare management within that facility. And because how this changed the situation, this allocation, workload determination, and setting of the remedial plan assisted the facility to have clear tasks for the HRH, and having a more targeted support to the HRH, allocation of targets that reduced to the time wastage, prolonged consultations, disagreements, obvious mistakes, industrial unrest, and most important, there was a lot of perceived workloads because of those kind of things. But what is also more important from the service delivery perspective, this was an initiative which was focusing on enhancing the capacity of the facility to respond to COVID-19. So the facility also the activity worked with the facility to integrate the COVID-19 services across service areas. So the integration included the integration of scope of work on COVID management within the scope of work for the healthcare providers, capacity building sessions, setting of clear targets for COVID response initiative and management, revision of the work schedules, development of simplified standard operational procedures. And from this, the COVID-19 services were effectively integrated across service areas. So out of this, there was significant, we call it significant because these are the changes that has been realized only within 8 months. And these changes are the workload-related changes, and some of these are reduction of working hours. So there was a reinstatement of working hours back to 10 hours from 16 hours, but also reduction of client waiting time to an average of 1 from 3 hours, and also extended availability of service at the outpatient department, which used to end at 5:30 p.m. but then was extended to 9:30 due to reintroduction of shifts, and smooth integration of health education, vaccination, and management within other routine essential health service provision. And as well, most significant achievement, which is more of service delivery, was an increase of vaccination from an average of 92 vaccination, which has been administered in a month, to over 420 vaccination coverage. So what does this case study tells us? Tells us investment on HRH is key, and especially now in COVID-19, when we are talking about moving from emergency response to building resilient system that will make the facilities being ready for preparedness, so readiness, preparedness, and ultimately ensuring the system can sustain provision of integrated and essential health services. Thank you very much.
You're welcome, colleagues, to this session. Yeah, as earlier mentioned, introduced, I'm Dr. Herbert Samba from the Joint Clinical Research Center in Uganda. Oh, need to get closer? All right, sorry, I can raise it. Yes, I'm here ideally to share our experience working, creating an enabling environment for health workers to be able to provide health services to the community. And this we are going to see through the supportive leadership that was seen in Lango. Since the 1990s, Uganda has been implementing a decentralization system of health services. This idea translates into the lower level administrative units taking over service delivery and management at the lower levels, with the center really doing the policy design and the like and support supervision at that level. This therefore calls for a lot of lower level engagement and leadership. Unfortunately, it is not something that we see consistently all the time, and we may not be able to see very good results when it is lacking, much as it is essential. And it is also not unusual to have health workers kind of become resistant to new programs, especially when they are not coming with special funding, as they see this as additional workload. However, we see in the case I'm going to share here and at Otwal Health Center in Yam district, the facility overcoming that. And this it was able to do through really the good leadership of the in charge of the facility in the name of Teddy. She created a very conducive environment with very clear communications and role clarification and allocation, provision of resources that really enabled the team to perform. Key strategies here was effective communication. On being supported by our program to identify the needs in children living with HIV gaps in terms of viral load suppression and retention in care and viral load coverage, she was able to bring her team together, take them through the problem to create harmonized understanding. From this, they were able to come up with a steering team that would really lead this work to the next level. They agreed on the key roles that have to be played, and they were assigned to the team. And she ensured that resources were available. And this really involved reallocating resources that were obtained from the result-based financing. In Uganda, there is a result-based financing program that is funded by the USAID and implemented by Enabel. And it happened that one of this site was one of such sites that are in that program. So she was able to utilize some of those resources that have been obtained through results-based financing to allocate to this. And there were human resource issues there. She actually allocated some money towards hiring a local midwife to support care for the children and adolescents. She actually also allocated funds to hire a local lab staff to ease the process of running samples and testing the samples for viral load. Yeah, on top of having the resources there, and it was also made possible to build capacity. She herself and the team engaged community health workers to reach out to the children and adolescents who were not doing well clinically and not suppressing. And this happened that they mapped out the clients based on where they live and based on their suppression needs, and each of them was attached to a community health worker. To ensure quality, since the community health workers are lay providers, each of the lay provider was in turn attached to a trained health worker to ease the support. To monitor performance and ensure that really the agreed activities are implemented to dot, there were regular meetings that she supported and always chaired as the leader. From these interventions, we did realize that there was improvement in community health worker patient attachment, to the tune of having a community health worker being attached to 15, up to a maximum of 15 children living with HIV. And this was really improved the care and the follow-up, minimizing missed appointments and the attendance to the clinic and receipt of services. There was better attitude for staff towards attendance to duty and also service provision. We also realized that there were system redesigns. For example, regular meetings were not part of the day-to-day running of the facility, but however, they became evident. Quantitatively, we see an improvement in viral load coverage and suppression over the 9 months period, improving significantly. We also see improvements in retention to care at 6 months and at 12 months. Yeah, and we realize that one of the key messages we learn from here is that good leadership supports health workers to embrace and effectively perform tasks for improving patient care programs at health facilities. And therefore, good leadership should be promoted for better HIV care. Yeah, John Adams, the second president of the United States, once was quoted saying, and I quote, "The best leaders possess qualities of humility, honesty, and cooperation. They are able to clearly communicate to help others take action. Great leaders not only inspire and motivate others, but also teach people the skills they need to achieve the goal of the team and the company, organization, or project." We really see a great leader in the character of Teddy, because she did achieve all this, and we see significant outcomes from this. Yeah, I can't end without appreciating the different stakeholders that made this work possible. Thank you for listening.
Good afternoon, colleagues, and to the virtual colleagues online. I am Chantal Smith. I'm the technical lead at Match Institute. Match is a district support partner in South Africa. We work in two provinces, the Eastern Cape and KwaZulu-Natal. Our core focus is HIV care and treatments, including TB, and we are supporting both public sector facilities for the improvement of HIV uptake of services as well as your prevention services. For the focus of this presentation, I'll be speaking on how we optimize virtual platforms to improve our mentorship program to healthcare workers for the uptake of PrEP amongst adolescent girls and young women. And so as implementers, we know that in order for a health system to be effective, you need to have qualified, resilient, and accessible health workers and human resources. And as implementing partners, we are well aware that with the costing and the funding cycles, there are always drops on an annual basis in terms of the amount of funding that we receive. However, our targets still remain the same, and so does our coverage. Unfortunately for us as partners, we are still expected to cover our targets and also cover our coverage. And to do this, we would need support from our ministries of health, especially our teams on the ground. To mitigate this, it means that we need to train staff, but also ensure that staff are mentored and capacitated in order to conduct the expected outcomes and also to meet the targets assigned to our programs. As Match, after our Q1 performance for PrEP, we noticed that we had only achieved 13% against our quarterly target, despite conducting centralized training both in person and virtual. So to mitigate this, following a rapid review on the gaps within our program, we noted that continuous mentoring is required for improved performance. And because of the low coverage of human resources within our technical team, we optimize on using the WhatsApp platform to provide mentoring to healthcare workers across facilities within the peri-urban district of Buffalo City. As part of our strategy, we had enrolled clinicians and non-clinical staff from 48 facilities onto the WhatsApp platform. As you know, WhatsApp is an easy, downloadable, accessible, and low-cost platform. So it was easy to get buy-in from healthcare workers to utilize this platform. On WhatsApp, we had project manager who facilitated discussions. These discussions included providing updates on clinical guidelines, standard operating procedures, as well as discussing daily reach towards targets. So each facility was assigned a PrEP initiation target, and this was also then de-escalated to clinician level. So on the WhatsApp platform, clinicians were able to discuss on a daily basis their reach towards target, any challenges that they were experiencing, and also share best practices and how to optimize workflows. On the platform, we also shared IEC material to educate clinicians on the current resources to improve uptake within their facilities, and we had also ensured that capacity was built in the various program areas. If you look at the graph on your right-hand side, you will see the quarterly performance from Q1 to Q4. You'll see that at the end of Q1, we were just sitting at 9% reach against target. So your blue bar is our performance, the green bar is the target. And from the implementation of the change idea in Q2, you can see an upward trend in performance reach. So at the end of Q3 and Q4, we had overachieved on the PrEP initiation rates amongst clinicians within Buffalo City Metro. And so what are the key lessons that we've learned from providing virtual mentorship? We see that there are numerous benefits both at an interpersonal as well as at a systems level. At an interpersonal level, the WhatsApp platform fosters support to health clinicians through engaging them and providing peer support in terms of mentorship. It also creates platforms for clinicians to share ideas across facilities and also to gain mental health and wellness support from their fellow colleagues. It also fosters greater buy-in because many programs are viewed as partner-driven, but when there is collaboration amongst departments of healthcare workers, you'll see that there's greater performance and support for the program. At a systems level, it strengthened our workflow optimization and improved task shifting, amongst various cadres of staff. It also fostered platforms for us to jointly think of innovative ways to improve our performance and to create various mitigation strategies that address the key challenges. And lastly, we were able to rapidly identify system-level challenges and jointly as a team provide quality improvement plans to address them. And so I'll close my presentation by saying that when we think of sustainability, we need to think about implementing activities that support the mental well-being and health of our clinicians, as well as activities that are low cost but high impact. And this will ensure that we gain increased buy-in from our departments of health and ministries of health. Thank you so much.
So thank you for those who are here and also for those who are following the presentations virtually. So my name is Phiri. I'm the Programs Director and Chief of Party of the Care and Treatment Program at Partners in Hope in Malawi. I'll be presenting on an assessment of burnout and depression among healthcare workers providing HIV care during the COVID-19 epidemic in Malawi. So the lead person on this work was John Songo, and he's following this actually virtually, and the rest of the PIH group. So just a brief recap of the Partners in Hope being care and treatment. This is a local partner in Malawi. It has the medical center, which is the hospital, with all the clinical care, plus also a robust laboratory, with a molecular lab that caters for 14% of the viral load monitoring and testing in Malawi. Then we have the programs, which has the clinical monitoring and evaluation and also the implementation science. And within the implementation science, that's where we have actual rapid assessments or protocol-driven research programs. So currently, the USAID-supported program is the client-oriented response for HIV epidemic control. This is actually the one which is being implemented in 123 sites in 9 districts across Malawi. We have a collaboration with University of California, Los Angeles, and also the Lilongwe Catholic Health Commission. The current cohort of the program is just over 200,000, and which is about close to 25% of the Malawi cohort. I will be talking about now in the workplace, looking at issues around burnout and depression, especially during the time of the COVID-19. The expectation was that we would have higher levels of burnout and depression levels amongst healthcare workers during the COVID-19 pandemic because of the anxiety and also increased work pressure. And we've seen before that, for example, our colleagues, our care and treatment also implementing partner, Baylor, they were able to see that there was already a high burnout rate amongst healthcare workers, and this was work which was done in 2016. So burnout and depression amongst healthcare workers actually would be able to reduce production and also can increase staff turnover. And this would ultimately reduce the quality of care that would be provided to the clients. So with this, we may have healthy outcomes of the healthcare workers in this case. So we're able to look at a survey to assess the prevalence of burnout, depression, and associated factors amongst healthcare workers providing the care. So we were able to survey 435 randomly selected healthcare workers in 27 health facilities within our PIH-supported facilities, which would be more of government, Christian Health Association of Malawi, and also private. The tools that we use the WHO self-report questionnaire, the SLQ for depression, and then the MASAC-2 for the burnout. When we looked at the healthcare workers, we were able to see that the median age was about 32 years, and 54% were female amongst those, and 34 were clinical cadres. These are clinicians, nurses, and also psychosocial counselors. And the lay cadres, 66%, who are these HIV diagnostic assistants and treatment supporters and data clerks. What we saw was that amongst the healthcare workers, 28% screened positive for depression. At the same time, 29% screened positive for burnout. And for both depression and burnout, we had about a 13% combo for screening positive. So in this case, the clinical cadre was associated with a positive burnout screen, and this was like 2 times more likely to screen for positive burnout if you were a clinical cadre, clinician, a nurse, or psychosocial counselors. When you looked at those who screened actually positive on burnout, they had a 3 times more likely screening positivity for a depression in this case. When you looked at those who were positive depression screened, these were also had a 2 times more likely to have, for those who were the previous COVID episode before, had a 2 times more likely to screen for depression. And we're able to see that those who were actually expecting to probably or definitely get COVID-19 in this case, where they had about a 3 times more likely in this case to screen also for depression in that component. So, what we were able to pick up from this was that Malawian healthcare workers who provided HIV services, in this case, are commonly screened positive for burnout and depression. But when we looked at comparing to previous surveys from Malawi and the region, we did not find that prevalence rates of burnout and depression were higher during the COVID-19 pandemic, because actually, when we looked at our sister partner, they were able to see about 62%. And in the region, we're ranging from 33 to about 68%. So what we looked at in this case was that there is already a high burnout and depression amongst our providers in our facilities. So therefore, as a program, we need to make sure that we put up strategies to support these, because as we know very well, we see that regular screening for both conditions should be encouraged, given consequences for mental health and work performance of healthcare workers in this case. So we need to look at feasible interventions for depression and burnout to make sure that these are available amongst the providers. As you know, for our providers to work very well, they need to make sure that the infrastructure is working well, and also make sure that commodities are available, and also to make sure that they are safe over there. So during this, we're able to put up programs in terms of supporting, so mental health support programs, and psychosocial counseling, and so provision of PPE during this time to make sure that they are able to do this work very well. So at that point, I would just like to thank the team at Partners in Hope, but also thanking the American people who are able to support this through PEPFAR and USAID. And thank you for listening.
All right. Thank you so much for the excellent presentations. So we have the rest of the time now for questions and discussion. So does anyone in the audience have questions for any of the presenters that have just spoken? If not, I have a few questions as well, but would like to see if anyone has anything you would like to clarify with any of the presenters or to hear more about.
Hi, thanks everyone for the excellent presentations. Dr. Smith, I had a question for you about the group. Did you have someone monitoring the conversations in the chat while they were open? And what was the cadre of those persons? So you had a clinician or other support workers who were monitoring the group. How did you manage the group in general?
I think they're turning it on, yeah.
Okay, so yes, we had a clinician from our head office that initially supported and coordinated the enrollment of the clinical staff and non-clinical staff onto the WhatsApp platform. As time went on, the process was actually owned by the facilities. So we got buy-in from the operational managers to be part of the WhatsApp group, and they were were able, on a rotational basis, to coordinate and support the discussions. One of the key things that we ensured was that we would have an expert from our team that remained on the group, just to address any clinical questions that may arise, and also to conduct case studies and case conferencing from the various dynamics or management cases that we're seeing. Thanks.
Great, thanks. Any other questions from the audience?
Good afternoon, everybody. I'm Dr. Mosadami from Botswana. I have a question for the last presenter who was talking about burnout and depression in the workplace amongst healthcare workers. I'm interested, Hella, to find out what are some of the interventions that are available to healthcare workers to combat burnout and depression that you are actually using in your country. Thank you.
So thanks for your question. As I was explaining, for example, is that considering that issues of burnout and depression would be available amongst the providers in this case. So we put up accurate strategies, and some of these, for example, is to look at we have the component of the mental health support, whereby we have availability of psychosocial counselors who would be able to have some one-on-one or group discussions with our providers to make sure that they are able to understand that these issues can be difficult time, especially when we are providing the COVID-19 services during the COVID-19. But we know that there are general things that we should be able to be provided too. So as I said, availability of commodities and the equipment for use, because that can be frustrating too. And also to make sure that they have enough infrastructure for them to do that. And sometimes whereby you are able to just bring them together as a team building so that they can be able to share some of these components that are utilized for us to do that component. I'll stop there for a moment. Thank you.
Yes, yeah.
Thanks. Sorry, can you hear me? Yeah. So my name is Sarah Page Mutongwiza. I'm with OFID in Zimbabwe, and I also wanted to talk a little bit about the presentation, the last presentation from Malawi. We're also been doing some work around mental health during the COVID time period, and working on healthcare workers screening using an online platform and mobile technology, because we felt that healthcare workers were not keen to come out to peers and to talk about some of the challenges they face around depression and burnout. So my first question to the presenter was, you did a survey. So who was doing the survey to the healthcare workers? Were they peers? Were they researchers? And what was a bit about the environment for the healthcare workers in terms of being screened? And then your recommendation for ongoing routine screening. I'd be interested in understanding how you see that happening. We have found that the uptake of anonymous mobile technology isn't that great. So also showing that healthcare workers maybe aren't willing to reach out to online, and that group sessions are actually effective for dealing with issues of people talking about prevention of depression and burnout. But I'd be very interested in hearing anything that you have found around that in your study. Thanks.
So thanks. That's those are two interesting questions and observations for this. So I'm a clinician myself, and that's true that probably coming out to peers would be an issue. So these the surveys were done by research assistants. So these would be like independent from our team to make sure that the healthcare workers would be comfortable to share some of these components within that. And then, in that case, we found out that response was actually quite better in that component. In terms of the continued screening, it's the same thing to say that we are looking at whether you want to use a mobile application, whether you want to use a paper-based. It is an issue that we felt that once we could ask in terms of which platform the healthcare workers would be happy with in terms of to be used for screening that component. And we were able to see a diversity for others who would want to do either a computer-assisted component or they would like to actually just do themselves and self-reported, and then they push back over that component. So there was a diversity in terms of the group that would see there. So when you're doing the programming, it means that you need to consider all those as you are doing the implementation. That's what I would say for now. Thank you.
We also have a question that's come in virtually through the online participants. So they're asking basically, in addition to things like group debriefing, what other types of practices can be adopted to support healthcare workers to improve their mental well-being and potentially improve productivity in light of lessons that we've learned from COVID? So I was curious if any of the four of you have any suggestions. Basically, going beyond just group sessions or debriefing sessions, we've talked about the importance of providing mental health support for healthcare workers. Are there other things that you would suggest that are important interventions to help reduce some of the barriers that you have seen that have been causing poor well-being and poor mental health among healthcare workers?
We're trying from there. Okay, thank you. So some of these, one of them is like a people-centered approach. And most of the time, we're told that the solution is being buried within the one who is affected by the certain services. So most of the time, on the management perspective, we are facing the human capital or human resources as recipient or providers, but not really as champions to provide solution that governs their environment. So that effective engagement of the health workers to identify issues within their environment. And the environment do differ. We don't have standardized solutions, but more customized solutions, and effective people-centered approach, engagement, and not only within the locality, but opening at an open dialogue of exchange with other colleagues outside their environment also provides a more natural process to absorb the mental illness or exposures to the health workers.
So just in addition to that, I think as the question is coming, it is very clear that amongst the counselors or the social counselors, there's already a program within their training which looks at to say that once they've done a couple of sessions, they should themselves also have some debriefing and to go through some of the issues. So that one is standard for counselors. For clinicians, nurses, and others, that's not a standard component. And also at the same time, we know that healthcare workers in this case are not really as good examples of health-seeking behavior. So I think in this case, I would propose that we can also, within our program, try to put a deliberate effort where we're encouraging our clinicians and nurses, whereby they can have a forum that we can discuss with colleagues, although they may not have, they may not want peers, but at least availability of the teams that are available that can support on their mental health and some other issues, just to talk about and on some of these recreation, take them out and talk about these issues and to see what are the key drivers of their probably challenges at the workplace. So that's what I would say for now in this case. Thank you.
Thank you both. Those are excellent responses, and I really appreciated, in particular, Rahel, I think your comment on, we use people-centered approaches with clients. Why aren't we using more people-centered approaches with healthcare workers? Is really important, because I think it's easy in the very data-driven, target-heavy world that PEPFAR operates within. It's easy to lose track of the fact that all of those numbers are services that are being provided by individuals, and those individuals are the healthcare workers that we support through our programs. And so I think keeping this front and center focus on health workers themselves as key stakeholders who we should be routinely seeking feedback from as we're doing our programs, and not just as sort of tools to help implement target achievement or work towards achieving results, I think is a really important point. Any other questions? I have maybe one or two more before we finish up, but I wanted to see if anybody else from the audience has any other questions that you would like to pose. If not, Herbert, I also had a question for you about, for your example of the case of the health center. You spoke a lot about the good communication practices that the in charge of the facility used to try and help get the staff on board. How did the staff respond initially to that, and then over time? Like, what was their initial response to this new quality improvement effort? And then how did they respond over time? And what kind of back and forth was there between the in charge and the staff that helped achieve those results?
All right, thank you so much for that. Yeah, in the start, of course, they weren't very positive about this new kind of program that was coming up. But through the regular interactions, yeah, like I mentioned, there were frequent meetings, probably weekly. Actually, they were happening weekly, that were engaging within the team. And through those, feedback kept on coming in, and they were also sharing their challenges, and jointly the team was agreeing on way forward on some of those. And within those meetings still, there was performance review. They would agree on the tasks that have to be taken, and then they would reflect on the previous week's tasks, and then address any changes that were emerging there. And in a way, the health workers felt more comfortable and got more positive about the new project. Yeah, and actually, I remember one of the quotes that was received was made by one of the health workers, was quoted saying that we are very happy with our leadership because it is very transparent. You get to know what they feel about you and help you address the challenges you have. So in the end, it actually turned out to be very positive relationship.
Thank you so much. And then I have one last question, Chantal, for you. Could you speak about how you talked about the way that how the goal of the WhatsApp group and the communication platform was to be able to provide mentorship between different types of providers. Could you talk a little bit about how it improved coordination specifically between some of the different cadres of staff? I think in your original abstract, you mentioned, there were some divisions between some of the lay counselors and nurses, or people weren't really cross-sharing information effectively. How did this group improve that?
Sure, thanks, Sherilyn. So one of the key things that was part of our enrollment process was that it included both clinicians and non-clinicians. So it fostered that sharing of knowledge and also sharing of expertise. And so through the process, we were able to ensure that inclusivity was being made possible in order to ensure that program performance was being achieved. And so we had various cadres of staff. We had professional nurses, your lay counselors, as well as mobilizers who were responsible for demand creation. So that process of inclusivity helped with the coordination of workflow processes, as well as the coordination of task shifting, and also the sharing of various ideas and also integration of services. So we saw that across the program and across both the care and treatment and prevention program, that there was a better integration and more a higher sense of accountability and ownership, because cadres were now more compliant or more at ease to share their ideas, as well as to receive input from junior and senior staff members. Thanks.
Great. Thank you so much for your response. And we're at time for this session. So please give a large round of applause to our presenters. And thank you, everyone, for your participation. All right. Thank you so much for joining, everyone.